So I'm going to point out one more thing on here. I want you to notice that the heart is kind of laying on top here and it's kind of obscured, but this is your heart. Notice in this other, in the second one, so this I would say is a pretty bad pneumothorax in number 1, but in number 2 it's even worse. Let's look at number 2. Where's the heart in this one? Look how far it has been pushed over. This is where this lung has been pushed so far over that the heart is actually being pushed over as well. And this will cause, sorry, I did it the wrong way. When the heart gets pushed over, it actually gets squeezed a little bit, and we end up with some decreased blood pressure and decreased venous return to the heart because it's actually being pushed anatomically out of the way. That's the other thing. So when I show you your worsening symptoms, I will kind of refer you back to this drawing here. Let me clear this out. And I don't know if you can see here on this number 1 drawing, this is your trachea right here. And on this one, your trachea is kind of pushed over this way as well. So this is your trachea, and everything has been pushed over. It's called deviation. So your heart is kind of squished over here. Your trachea is squished over here. That is a very late and actually pretty bad sign of a pneumothorax. So that is a, number 2 is a late or a worsening pneumothorax. This one is kind of moderate. It's not exactly early, but the heart and the trachea have not been pushed over to the side yet, and so that is something that's considered a little more mild, possibly treated a little differently. Hemothorax, I'm going to show you, is fluid in the space. It's very hard to tell the difference here, so you can see in this one, I always try to go drawing and then I flip the screen forward. This right here is where they're showing you the hemothorax. This is white because it is fluid. Someone said, how can you tell the difference between pulmonary edema and hemothorax? It is hard to tell the difference between the two. That's why we don't read chest x-rays. We just read the results of it. And know that if they usually go off of the causes. They can't really tell whether this is pulmonary edema or whether this is hemothorax. It's a lot brighter than pulmonary edema fluid. But what's the difference between this and a full-on ARDS whiteout? Well, one, it's unilateral. It's close. It's only down in one lobe. It's at the bottom. It is fluid, but they will go based on what the signs and symptoms are presenting. If this patient has a broken rib at rib 5 or 6, that could be causing a puncture that would cause bleeding into the lung space. If they've had recent surgery, that could be blood. If they've had lung cancers that are leaking, inflammatory, there is some kind of fluid in there. Could you tell the difference between a pleural effusion and a hemothorax on a chest x-ray? No, you cannot. That could be a pleural effusion, that could be a hemothorax. We don't know the difference between the two. It's just fluid. They will usually go off of what happened to the patient to determine whether it's blood or effusion, but the treatment is the same, whether it is inflammatory effusion collection or whether it's a blood collection, the treatment is the same. So they really go off of the symptoms on there. But let's look at our symptoms. I put all 3 of them together because all 3 of them have the same symptoms, because it doesn't matter what you have in the pleural space, whether it's an effusion, which is inflammatory fluid, pneumothorax, which is air, or hemothorax, which is blood. You have inflammatory fluid, air, or blood in the pleural space. And the reason you see the symptoms that you do, let me draw my, going to draw my in pleural filling here. So now I've got, let's say, inflammatory fluid leaking, excuse me, in here. So now I have inflammatory fluid in the pleural space, and that is filling up this pleural space here. If I have inflammatory fluid in this pleural space, one, it's going to decrease the amount of air, and every time we inhale and make that lung big, it's going to push up and irritate against the side. So this air-filled thing is going to have a whole line of irritation there. And that irritation is going to get worse every time you breathe in. So every time you breathe in, that undamaged piece of lung is going to be rubbing up against either air that is not lubricated, blood, which is an irritant, or inflammatory fluid, which is an irritant. It's going to irritate that lung, and it's going to be worse with inspiration. So pleuritic chest pain is pain worse with inspiration. Your breath sounds are diminished, and let me show you why. Let's draw a little stethoscope here. So let's say you have your beautiful purple stethoscope, and you are listening to lung sounds. You are trying to listen through fluid. So you are trying to listen through fluid, and you are having trouble hearing air moving in and out because there's a lot of fluid blocking in between you and air movement. So your breath sounds are diminished or absent because non-exchanging fluid, effusion or air, does not make noise because it's not moving in and out. It's just trapped. And you're trying to listen through this trapped stuff into your lung space, and so you can't hear the actual air exchange. Breath sounds are diminished or absent over the affected lobes. Dyspnea, shortness of breath, tachypnea, and tachycardia. This is our body's response whenever we have trouble breathing. I told you that tachycardia and dyspnea were early signs of ARDS. So what makes this different between ARDS and pleural space disease? What's the difference? The difference is the lung sounds. In ARDS, you have crackles. Crackles are the sounds of when we listen with our stethoscope. So let me draw our beautiful purple stethoscope here. So we're listening to the lungs, and we are listening in here. What we are hearing is we have fluid in this space, and we are trying to bubble CO2 and oxygen through that fluid, and we hear that bubbling through the alveoli, and that sounds like crackles. It sounds like popping. It is air popping through fluid. And so when you inhale in and take a deep breath in, you are hearing oxygen and CO2 transmitting through that fluid. They're trying to get through the fluid, and you're hearing that as crackles. You can actually hear rales too. That is kind of the sound of air bubbling in your alveoli. So the difference between ARDS, effusions, pneumos, hemos is your breath sounds. With a effusion, pneumo, and hemo, the fluid, so let me get rid of this, the fluid is in here. So let's draw the fluid. And now we have fluid or air or blood or whatever it is in this space that is now blocking the sound. And on the inside, you may or may not have normal sounds. We've got air moving in and out. Maybe this alveoli is perfectly healthy. Air could be moving in and out, but you cannot hear through the fluid. And so you don't know. It could be that the whole thing is squished. So let's draw. No, don't get rid of my stethoscope. Hang on, let me erase my alveoli. Oh, I erased the whole thing. Darn my beautiful drawing. Let's say that we have squished this alveoli because now this fluid is filling up this space and the alveoli is squished. What will you hear with your beautiful purple stethoscope out here on the skin surface? What will you hear? You will still hear diminished breath sounds because now you're listening through fluid, but now there's no air in this collapsed alveoli, so of course it becomes more diminished or absent. So the difference between early ARDS or late ARDS and effusion, pneumo, hemo is the difference between what are we listening to. If we are listening to pulmonary edema or fluid in the alveoli, we are hearing popping, crackling, we're hearing rales and crackles. If we are listening for effusion, hemo, pneumo, we are listening for the sounds of atelectasis or collapsed airways, because as the effusion grows, it will collapse airways, or we can't hear through the fluid, so diminished or absent breath sounds in effusions, pneumos, and hemos. How do you know the difference between an effusion, a pneumo, and a hemo? You really don't. They go off of symptoms, and they'll go off of maybe going to look for the actual kind of fluid. But if there is an infection or an inflammatory process, they're assuming that it's an effusion. If they have had a reason for a burst alveoli, or they see a lot of air on the x-ray, they will go with pneumothorax. And if they see fluid, like I said, they will go kind of off of the presenting situation to decide effusion, hemo, but they all have the same treatments. So that's why don't worry about diagnosing them. You're not a diagnostician, you're not a radiologist. That's the job of the radiologist. It's our job to read the chest x-ray and understand if they say effusion versus infiltrate, or if they have both. If they have an effusion and an infiltrate, you know that they've got fluid in their alveoli and fluid outside in their pleural space. If they have an effusion, it's just in the pleural space. If they just have infiltrates, it's just in the alveoli. To know those terminologies and understand what that means, because there's different treatments. If you have pulmonary edema, infiltrates, what are our treatments going to be? To figure that out, if we have pulmonary edema, infiltrates, we're going to go back. I went forward. I meant to go back. We're going to go into the interventions for what are we going to do if you have a lot of fluid in your alveolar space. We're going to possibly reposition you, get positive pressure ventilation to get oxygen through the fluid. We will try to remove the fluid, and we will mobilize secretions because the fluid is in the alveoli. That's with infiltrates and with edema. So this is the treatments. I'm just going to reiterate this again because I think this is really important. These are the treatments for pulmonary edema, pulmonary infiltrates, and these are synonyms. They mean the same thing. Pulmonary edema, pulmonary infiltrates. Well, my drawing just does not want to stay. So you can go back to this slide and write, these are the treatments for pulmonary edema and pulmonary infiltrates. Hey, and that works with your heart failure lecture, because guess what you give for heart failure patients that have fluid in their lungs? You're going to give them diuretics and antibiotics, and then if they need to, you can move up. If it's not working, you can move up to positive pressure ventilation. So it's not purely, I shouldn't even say it's purely for adult respiratory distress syndrome. Those are our treatments for any time that we have fluid in the alveoli. And your eagerness to get these things started is going to depend on your oxygenation. But if you have a lot of fluid in your alveoli, if it's localized and only in one lobe and not affecting your oxygenation, well, then we can still use diuretics and antibiotics to clear that out. But if you have fluid in a lot of your alveoli, you have a lot of pulmonary edema, you have a lot of pulmonary infiltrates, then that becomes a priority because your oxygenation is not so good. So fluid in alveoli have certain interventions, and then we have fluid in the pleural space has different interventions. So these are the interventions for if we have, come here, drawing. These are pleural effusions, pneumothorax, hemothorax. This is stuff in pleural space. It's not infiltrates. It's not pulmonary edema. It's not pulmonary infiltrates. It's called pleural effusions, pneumothorax, hemothorax. So when you're reading those chest x-rays and you're looking at radiology reports for what's going on in your lungs, those are the words you're going to look for. Look for pulmonary edema, look for pulmonary infiltrates. That's to lead you to alveoli problems. And effusions, pneumothorax, hemothorax lead you to pleural space disease. Those two have separate interventions. So the pulmonary edema, pulmonary infiltrates have diuretics and have antibiotics and have things like that. The pleural space diseases will have either just give oxygen and watch it. Because if this is a tiny effusion, pneumo, or hemo, then eventually this will get reabsorbed into the bloodstream. So I'm going to draw my little alveoli again. We love drawing this alveoli. And we have our little capillary. What's going to happen is we had some kind of, let's just say we just had a pleural effusion. Maybe this is a little cancerous cell. I don't know. Maybe we got a pneumonia in here. But we have a little pleural effusion. It's a little collection. It's not a real big thing. They see it on x-ray. There's no shortness of breath, maybe a little bit of decreased oxygenation. Anyway, an effusion that is small will eventually get reabsorbed as it gets cleaned up. It'll get reabsorbed into the bloodstream. So eventually, over time, this will get cleaned up by your body. If they ended up giving them diuretics and that dried out the blood space, that might pull it in even more. But eventually, a asymptomatic pulmonary effusion, pneumo or hemo, will have everything reabsorbed into that space. If it is a very large one, so let's draw this, and now we have our, redraw. Where's my purple alveoli? Let's say we have a large one that has collapsed our alveoli, and we have a huge amount. Let's call this one a hemothorax. We've got a huge amount of blood in this space. It's going to be a long time before we can reabsorb all of this. And so what they need to do is put in a drain to drain it out. And so we need to remove that fluid or air out of that space because it's caused collapse. So if it is causing shortness of breath at rest, decreased oxygenation, then we don't have time for weight to get reabsorbed. We're going to put in a drain and remove it. That drain can be a needle or a chest tube. And so our stuff in the pleural space, it's either asymptomatic or mild, and we wait for it to get reabsorbed, in which case we would keep monitoring their oxygenation, monitoring their chest x-rays to see if it gets bigger. And if not, then if it's not getting bigger and it will slowly get reabsorbed, they'll leave it alone. But if it is causing shortness of breath at rest or decreased oxygenation, then they will put in some kind of needle or tube to remove the stuff from the pleural space, because remember, it is trapped and the only way out is to get reabsorbed. So the two procedures that we have are the chest tube and the thoracentesis. The thoracentesis is not something that we can do. The thoracentesis is something that a healthcare provider would do, and they physically will drain pleural fluid out of the space by dropping a needle into the space. This is the goal, is to draw fluid out of the actual pleural space. But you can see this would not be the goal to hit the lung, and this is not the goal to hit the liver. Bad ideas, both of them. So you can imagine what our side effects could be if they hit the wrong thing. It's also why you don't want to cough during the procedure, because guess what sits right above the liver here? Is the diaphragm. So you go to cough and drag that diaphragm up into the needle space, you could pop the diaphragm. If you inhale to cough, you could bring the lung down into that needle space. So we want to avoid the patient coughing during the procedure. We want the patient sitting upright because that will dump fluid down to the base. We want the fluid dependent. So if the patient is sitting upright, all that fluid sits at the base of their chest and makes for a much easier stick there. So we want them upright, or put them on their side with their arm up over their head, and they will aim for the most upright part of the lung, which would be on the side there. So you can lay your patient on the side and they will aim in from the side. But we try to get the fluid dependent as possible, so that when they do poke through that needle, there's less of a chance of hitting lung, diaphragm, or liver. So those would be your side effects here, or what we don't want to see after the procedure. We would like to see our lung expand, pleural fluid removed, but we don't want to see a puncture to the lung, a puncture to the liver, or a puncture to the diaphragm. So common sense wise, what we expect afterwards is the dressing over the puncture site. It should just have a little bit of drainage coming out of it, whether you drained effusion, air, or blood. If you drained a hemothorax this way, you might see a small amount of bloody drainage, but it should be a small amount. Continued drainage means that something's still continuing to collect in that area. Position on the unaffected side. So that means the lung that got the puncture needs to stay up in the air. So position them on the unaffected side. So if you punctured, so this little lady on the slide before, we are puncturing her left lung. So how would you lay this person afterwards? You would lay them down in the bed on the right side. You want that you want the affected lung, or the area that has been punctured, to be upright so that it can expand a little bit. It has more air rises, and so that will help it expand. You want the punctured side to be up in the air. So does that make sense? If you're going to if you're going to puncture the left side, you're going to lay them on the right side afterwards. And let me just draw. So let's draw that we're going to puncture this little person here. So let me draw I love drawing people, even though I'm really bad at it. So we have, those are his lungs. And we have punctured into the pleural space on the right side. So that right lung was collapsed a little bit. Let me draw my right lung a little bit collapsed so that you can see. So we drew, here's your left lung, looks great. And your right lung looked a little shriveled. And we pulled a whole lot of stuff out. So we took stuff out of the, let's see, this is his right side. His left lung was great. His left lung looks great. We want the right side to stay upright so that after this, after we've pulled all that fluid out, now this lung, air will rise, and as you inflate air in, air will rise and it will re-expand this lung. So if you puncture the right side, that side needs to stay up. So he needs to lay on his left side. You will leave them on the side. If they're laying laterally, we will have that right side up to puncture it. You leave them laying on their left side so that that right lung can re-expand. Okay, hopefully that wasn't, well, it's probably not the best color picture I could do, purple on blue. But anyway, we want them laying on the unaffected side or the unpunctured side for at least an hour so that lung can re-expand. You will be keeping an eye definitely on their oxygenation, respiratory rate, lung sounds, heart rate, blood pressure, because the two most common complications after we put a needle in there would be a pneumo. If you hit a lung, you could give yourself another pneumo. Maybe you drained one out. Maybe you drained pleural fluid, but now if you puncture this hole, this will expel air back into the pleural space and you'll end up with a pneumothorax. So you'll be constantly listening for diminished breath sounds on that side for a pneumo. A hemothorax would be bleeding from that lung. Maybe it punctured a vessel there. Also any bleeding of the well, actually, if you puncture the liver, it should not go into the pleural space because the diaphragm is in between it. So if you puncture the liver, where the liver should not bleed out into the pleural space. But if you did puncture the liver, it would slowly start to ooze. So you might see some bleeding in the abdominal area. If you puncture the diaphragm, that might paralyze the diaphragm and cause some trouble with inhalation. But basically, you're looking for bleeding. If the lung started to bleed, if you punctured the lung, that could bleed into the space. You could get air into the space. There's so many things that could happen when you start sticking needles around lungs and vital organs. So you want to make sure that no air gets punctured, that no blood has been punctured. You're going to be listening to that affected area to make sure it re-expands and that there's no side effects, the side effects being a pneumo or a hemo. The other side effects would be diaphragm injury or internal bleeding, like if they hit the liver. So keep an eye out for those signs and symptoms after a thoracentesis when we've removed fluid from the thoracic space. And then we will talk about chest tubes. So chest tubes are our Foleys for the pleural space, and they are drains. So we're going to talk about Foleys next. Take a little bit of a break if you're in the mood for a break, and I will be right back. Okay, so the chest tube is a Foley drain, basically, for air or fluids that are trapped in the pleural space. So chest tubes are only for things in the pleural space. So they are only good for, they're only treatments for that's the wrong color, for effusions, pneumo, or hemothorax. So those are the three conditions that we would use chest tubes for. They're not indicated for pulmonary edema or infiltrates because they are not going into the alveoli. They're only going into the pleural space. So they're only appropriate for pleural space diseases. So for a patient with pulmonary edema from heart failure, a chest tube would not work because the fluid is in the alveoli, not in the pleural space. So if the patient had pulmonary edema, they would have fluid in, if we look at our little lung here, they would have fluid in the alveolar space, and you can see the chest tubes don't go in there. Chest tubes sit outside the surface of the lung. They can't get into the lung. They never can. They never will. So they are not appropriate for pulmonary edema or infiltrates. So just put that out there. Procedure for chest tubes is only for things in the pleural space, which are effusions, pneumo, or hemo. There's two places they put them in. Again, we don't put them in. Providers put them in. They go in high if we're trying to remove air, because air rises, and they go in low if we're trying to remove fluids because fluids are dependent and they drop down low. So chest tubes are put in one of two places, whether we have a pneumo to get rid of or a pleural effusion or a hemo. So this would be, they would put them in high for a pneumo, and they would put them in low for an effusion or a hemothorax. So those are where chest tubes would go. The physician will put them in before. The job that we have for them is to get consent from them. This is a consented procedure. It's an additional procedure. We set up the chest tube suction and drainage system that gets connected. We position the patient, the affected side up, again, like a thoracentesis. We want the side with the fluid or the air to be upright so that we can puncture it with the chest tube in the right place. So patient upright in the forward position, like for a same positioning as a thoracentesis. Upright or arms up over the head, stretches the space, allows the tube to go in. And again, avoid coughing during the procedure, because this procedure really isn't that much different than a thoracentesis. It's just instead of putting a needle into the space, we are putting a flexible silicone tube into the space. Make sure you take a look at the chest tube video that is linked in your module, because that one I do show you a couple of chest tubes and the actual drainage systems in more detail. What we expect after the procedure is we expect the tube to remain inserted. If they were just doing a one-time procedure, it would be a thoracentesis and they would remove the needle. We expect if they're having a chest tube that tube is going to remain in place, that dressing over the insertion type should, dressing over the insertion site should be Vaseline gauze or some kind of impregnated gauze to keep air from getting in and out around the site. So some kind of impregnated gauze wrapped around the tube to reduce the air, like I said, escaping or getting into the chest cavity, and then covering that with a dry sterile gauze. It could be taped any way, shape, or form. Just keep it taped so that the tube does not come out. Again, they might suture it right to the skin where it exits, but there will be a dressing over it. And like I said, that is usually, let me draw the dressing on my little lung thing. So here we would wrap a little piece of Vaseline gauze around and then lay a 4x4 over it, and you can tape it down however you feel. But that will keep this site clean and free from infection and free from getting air in and out. The chest tube drainage suction device should be attached and functioning. Again, watch the video on chest tubes. I do show you the chest tubes and how we put them together and how we get them hooked up to suction. We do expect pleuritic chest pain. Again, every time we inhale, guess what this is rubbing up against? It's going to rub up against this tube that's in the place. It's going to hurt. And so every time we take a deep breath in, it will rub against that chest tube, and it will cause pleuritic, worse with inspiration, chest pain. If you take a listen with your stethoscope here, let me draw our little purple stethoscope. If you're taking a listening through here and you're trying to listen with your stethoscope to lung sounds here, you are hearing this tube and you're hearing the lungs rub over it. You're hearing lungs with every inhale. You're going to hear a little squeak noise, and that is called a friction rub because you are hearing the actual lung rubbing on the tube every time they take a deep breath in. So with each inhale, you'll probably hear air and then a squeak at the end, and that's actually the lung squeaking against the chest tube. And of course, your patient will probably complain that it hurts them. It does hurt them. It is a tube sitting in between in a space where there is usually a tube. It does kind of hurt a little bit. So you can tell them that is expected and what is going on there. But we do expect pleuritic chest pain, and we do expect a friction rub afterwards. We do not expect, again, if you are treating a pneumothorax, that pneumothorax should resolve and get better. We are pulling that air out. We don't expect a pneumothorax to develop. If it does develop, then we have probably punctured. This can also rub on the lung, and if as it's rubbing, if it punctures, a new pneumo or a pneumo that's not healing could be an indication of further lung damage, something that you might want to let someone know about. If we are draining a pneumo, it should improve with time. If we're draining a hemo, all that blood should come out into the drain, and you'll see it come out, and the lung sound should improve. We don't expect the chest tube to become removed. We don't expect any diaphragm injury. We don't expect any punctures or bleeding. Again, most of the same things as the thoracentesis. We are just looking to not introduce new injury to the site. We want to drain air or blood or fluid that was there, but we don't want new air, blood, or fluid draining out of this thing. That would be something that we would need to call somebody about. Or if they're starting to have asymmetrical chest expansion or shoulder pain. Left shoulder pain is usually referred pain from the diaphragm. So some people will say that if you have a diaphragm injury and you have left pain, that is the pain from the diaphragm. The diaphragm doesn't feel pain where it exists. It refers its pain to the left shoulder. So sometimes anyone that has surgery around that area or has surgery around the diaphragmatic area may have left shoulder pain. That's pain to the diaphragm. Anyway, so we're going to talk a little bit about the chest tube drainage suction device. We expect that to be draining and functioning as ordered. And we never, ever, 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 ever clamp chest tubes unless we are changing out the drainage system. That is the only time that you will clamp a chest tube. Well, actually, not the only time. The only other time is with a physician's order. So the only 2 times you will clamp a chest tube is to change the drainage system, to actively physically change the system. For the 30 seconds it takes to change the system, you will clamp a chest tube, but that's it. And then if a physician orders it, you can clamp a chest tube, but otherwise never, ever, ever clamp a chest tube. So let's talk a little bit about the chest tubes. And again, watch the chest tube video. I will show you the actual physical chest tube and how it works and the bubbling and everything. But chest tubes are composed of 3 chambers. The one is just the Foley, just the drainage chamber, okay? A Foley only has a drainage chamber, right? The Foley just drains out into its urine drainage container, and that's it. The chest tubes, because we can't just drain, we want to avoid air from getting into the chest, we now have an basically an access, a tube into the chest. If this person decided to take a big breath in without these other two chambers, they would just inhale air in through their hole in their chest and never ever reduce their pneumo, hemo, or whatever. So we have two additional chambers in a chest tube. One of them is to control the suction, mostly because chest suction to the wall is not regulated very specifically. The wall suction can go anywhere from 20 to 400, and we don't want the wall suction being what's actually being suctioned on the chest, usually because it needs to be much, much lower suction to the chest wall. Otherwise, we'll damage the chest wall. If you put 80 millimeters of suction onto a chest wall, you're going to suck the lung into the chest tube. So we want the pressure that you're suctioning with to be very, very low. It's usually 10 to 40 millimeters of mercury is the suction that we use, and we want to regulate that very directly. So we have a suction control chamber in the chest drainage unit that basically takes the suction from the wall and reduces it even further to a safe amount of suction. So that takes care of two of your chambers that you have here. So this one is just basically the fluid drainage. If you have a hemo, you will see blood come out. If you have an effusion, you will have, so if you had a hemothorax, blood would come out of there. If you had an effusion or inflammatory fluid, then you would have pleural or inflammatory looking yellow fluid coming out of there. If you have air coming out, you may not have anything in this fluid connection chamber. So if you have a pneumothorax, I wouldn't expect to see a lot of drainage. You're not going to see air. So that's where you're going to have your fluid collection chambers there, and that's draining either blood, pleural fluid, or air, whatever's in your space. That's just the drain. The second chamber we have is a regulating chamber. So the first chamber is your drainage chamber. Your second one is you're going to regulate your suction at a lower amount. That is always ordered by the physician. The suction control is always ordered by the physician. The physician will write suction to 10, 40, 20, whatever the suction the physician wants is what is ordered. That is what you're going to do with the suction control chamber. And the third chamber is your water seal chamber. So that is keeping that water seal, is allowing air out. So this is what those yellow arrows are on this picture. So if you're draining your pneumo, air kind of rises. The air will be allowed to go out this way. So because we can't see air in the fluid collection chamber, this chest tube system's not going to blow up as we remove air. Air will actually be vented out of the system through the water seal chamber. It allows air to escape, but does not allow air from outside in the atmosphere. That water acts as a blockage so that air from the outside can't get, or air from our atmosphere can't get back into the lung. Every single chest tube needs a water seal chamber. That's what keeps air from getting back into the pleural space, okay? It allows air to escape, but does not allow air back into the pleural space. So every single chest tube should have a fluid collection chamber. Every single chest tube has a suction control chamber, but you may not need it. It's not required to be on suction. May not need it. The suction control chamber, it would help if I could draw, if I could spell. May not need. You may not need suction, but you do need a water seal chamber. So these two have to be engaged. Your suction control chamber may or may not be engaged, okay? But every single, at the minimum for a chest drainage unit, you should have your fluid collection chamber and you should have a water seal chamber. You do need both of those. Those are required. The suction control may not be required. So let's take another look at them. there are the 3 chambers, the water seal chamber. So the water seal chamber, again, is one of the required chambers. All chest tubes must have this chamber filled and functioning. And again, that is our one-way valve, allows air out, but does not allow air in. So any air suction from the chest is vented out that way, but air suctioned out from the chest can't get back into the lung space. It is a safety valve, basically, the water seal chamber. So we fill it up, and we just leave it as is. There is let me go back to the big picture here. When you breathe in and out, you will see this water level go up and down. And I do show this in the video. I'll show you titling and stuff like that when you watch the video. But you will see when you inhale air in and your lungs get big and the pressure gets higher, then that fluid level will rise. And when you exhale out, then this fluid level will go down. So there's a titling in that water seal chamber that you will watch that fluid level go up and then back down, and then up and then back down. So you will watch, and it's on the video. I breathe in and out to show you the titling. So if you see titling in the water seal chamber, that is a normal finding. It means that your pressures in your lungs are working the way they're supposed to. When you inhale in, the pressure goes up, and when you exhale out, the pressure goes down. So that is called titling, and you see that in the water seal chamber. So the water seal chamber should be full of water. There's a line that you fill it to. The water seal chamber should be full of water, and you should see titling, that water level going up and down. It should rise with inspiration and drop with expiration. So that's what you should see in the water seal chamber. The drainage collection chamber, you should see whatever's coming out. If you're draining a pneumothorax, you may not see anything in the fluid collection chamber, but if you're draining a pleural effusion, you'll see serous yellowy fluid in there. If you're draining a hemothorax, you're going to see blood in there. Whatever you're draining out of your chest cavity is what's going to show up in the drainage collection chamber. And the suction control chamber, again, like I said, you may not need it. It is optional. It's an order from the physician. It's not required for your chest tube to function. You do require the water seal chamber so that air can't get back into the pleural space, and you are required to be draining something. Otherwise, you wouldn't have needed the chest tube in the first place. But you may or may not need suction. Suction will re-expand a lung faster. If we put suction on, it will help pull fluid out of the space. It will help the lung re-expand faster. But it is ordered by the physician. It's 10 to 40 milligrams is the order. And I kind of talk a little bit about the dry suction system and the water suction system in the video, because I think it's easier to see in the demo video what I mean by wet and dry suction systems. But just remember, the takeaway from this is never use a water suction or a wet suction system, because they're just bad. Just get rid of them. They're stupid. They don't work. I tried to get them banned from Chandler. I probably say this over and over again. There's really no purpose to a wet suction system, but I do show you the 2 systems and what that means. The dry suction system is more specific. It's better for control of suction. It's a dial instead of a water chamber. It doesn't bubble in the suction control chamber. It doesn't cause confusion. A dry suction system is the one you're going to want. But I do need you to kind of understand that no matter what kind, whether it's dry or wet suction, you have a fluid collection chamber, a water seal chamber, and a suction control chamber. In the wet suction system, that's what this picture right here is, a wet suction control chamber, because the suction is controlled by how high the water is. So the water will be filled to a certain mark. If the water is filled to 10 centimeters, it's 10 centimeters of suction. If the water is filled to 20 centimeters, it's 20 centimeters of suction. On a dry suction control system, this is replaced with just a suction control chamber. There's no extra column of water, which I find a lot less confusing for people. So the only water in a dry suction system is the water seal chamber. In a wet suction system, there are 2 water-filled chambers, the suction control chamber and the water seal chamber. Again, please, if you have not watched the demo video, you need to watch the demo video to really to get your visual on how this all works. So again, this is another picture. This is the picture of the dry system. So the wet system, you see how it had a chamber of water. This is the dry system where you have your, this is your drainage. This is where everything's draining to. This is your water seal. And this is your suction control. So instead of a third column of water, you have a bellow. And that's the dry system, and I love it so much more because the only water that you see in the system is the water that's supposed to be there in the water seal chamber. So let's talk a little bit about what we're going to expect and unexpect on a chest tube. We told you about the 3 chambers, that the 2 that are required, which are the water seal and the drainage chamber, and the third that is optional, which is your suction control chamber. So in the water seal chamber, you expect to see the water filled to the line. We need to fill the water seal chamber. That's part of how we get the drainage set up, ready to go to the physician. We need to make sure this water seal is in there because this is our one-way valve. The water should be filled to the marked line, which is that little line you'll see on both of them. And then you'll see the titling, this little bitty ball here. Oops, go back. This little bitty ball here will rise and fall with each breath, and that is titling. You'll see that little ball rise and fall. You may see the level of the water in this side port. That's the titling. You want to see that. So let's talk about bubbling in this water seal chamber. So this is a seal that, again, does not allow air from the atmosphere into the lungs, but does allow air to bubble out. So if you see bubbling in the water seal chamber, it could be normal, it could be abnormal. The difference is that if you have intermittent bubbling, so if this is draining a pneumothorax, we expect to see bubbles in this chamber because this is the only way for air to get out. It's not going to sit in the fluid in the collection chamber. It's going to come out of the water seal chamber. So when do you think, if you are inhaling and exhaling, when would you push air out of your pleural space? If you had room to let this air escape out of your pleural space, so let me draw in here again let's talk, this is a pneumothorax. Oops, don't draw there. Hold on for a second. So I'm going to draw our little lung over here. Let's talk about, we had a collapsed lung. We have a good lung over here. We had a little collapsed lung because it had air in the pleural space. So now we have all this air in here. So this is air. Fill this up with air. And then we put a chest tube in because we looked at the x-ray, we didn't like it, and they put a chest tube in. So now air has a way to get out of this trapped space and leave. So all this air is leaving. When do you think, is the air going to be leaving all the time, or is the air going to be leaving on inhalation or exhalation? The air is going to be leaving, so let me erase all this. As the lung expands with each inhalation now, put it back in purple. As the lung expands, each inhalation, it gets bigger and will push air out of the system. So on inhalation, as the patient takes a breath in, you're going to see air escaping out of that chest tube. And this will happen on inhalation. You'll see air, so they'll take and you'll see bubble, 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 bubble. Because as that lung expands and pushes air into the tube out of the pleural space, I shouldn't draw it from the lung space, it's coming out of the actual pleural space. As that lung expands, air will escape out of the pleural space and go down and out into the bubbles. Okay, so air will escape out, and then when they exhale out and this lung contracts a little bit, they're not pulling air in from the outside environment because of the water seal. So every single time they take a breath, their lung expands fully and push air out. And so a pneumothorax, it is fine to see air bubbling in the water seal chamber, but only intermittently, only on inhalation. So as the patient goes, then you'll see bubble, 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 because the lung expands, pushes air out. But then when they exhale and the lung gets smaller, you're not going to see bubbles in there because nothing's bubbling through there. They're exhaling out, but there's no bubbles. So inhalation, bubble, 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 bubble. Exhalation, no bubbles. Inhalation, bubble, 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 bubble. Exhalation, no bubbles. That's what you expect to see, and you only expect that if they have a pneumothorax. So if they put this in for a pneumothorax, I would hope to see bubble, bubble, bubble on inhalation, because that means that air is escaping out of the water seal chamber where it is supposed to escape. If my patient did not have a pneumothorax, so we put in this chest tube and there was no bubbling in this water seal chamber ever, which is a normal finding if you do not have a pneumothorax, and now there is air bubbling, that is a new pneumothorax. It would be something that you want to talk to the doc about, but they already have the treatment in place, so it won't cause any problems. Intermittent air bubbling, or air bubbling only when they expire, is normal and expected if you have a pneumothorax. If you start to see it develop, then that means they're developed a pneumothorax, but you already have the treatment in. So we're going to document that the water seal chamber is full. We're going to document if they have intermittent bubbling. As this lung hole heals, so let's say now, let's draw a picture later on as this lung has completely re-expanded. So now we have our lung is completely re-expanded here. And all we have left in this space is the pleural fluid and the chest tube. So that's the chest tube escaping out here, or going into the drainage thing. As this fills up and the lung heals, now there's no more hole in the lung, so there's no more air to escape. Then the bubbling will get less and less and less, because as this lung expands into place and becomes fully expanded, now there's no air to escape out. And so now that this is fully re-expanded, there's no bubble bubble on inhalation because there's no more air left in that pleural space, and there's no more bubbling. And that is a sign of healing, as if you've had bubbling on inhalation and now that bubbling is going away. It's because there's no air to escape anymore. Things are healing. They'll get a chest x-ray to make sure that all the air is out of the space, and then they can remove the chest tube. So we're going to be watching that water seal chamber to see if we have a pneumo, if things are getting better, getting worse, because if they were bubbling intermittently and now it's going away, that means they are healing. If it wasn't bubbling at all and now it is bubbling intermittently, then that means that there's a new pneumothorax developing. Intermittent bubbling means pneumothorax. Continuous air bubbling in the water seal chamber means that there is a crack in the system. These systems, I don't know if you've ever been in the hospital or not. Let me go back and look at these. They hang on the edge of the bed when you transport people. They hang on the edge of the bed. They get cracked in elevators. I mean, you get dropped on the floor. They're just plastic cases. And if they get cracked and air can get into the system, then there will be continuous bubbling in the water seal chamber. Not just on inhalation, not inhale, bubble, 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 but bubble, bubble, bubble constantly in the water seal chamber is a sign that the system is cracked or has air continuously getting into it, and we would have to change out the whole drainage system. Or you've got to seal a leak somewhere in the system. Continuous air bubbling in the water seal chamber means there's an air leak in the system, a system problem. So intermittent air bubbling, normal if you know about a pneumothorax. It's a new finding if you don't know about a pneumothorax. So if there's never been any pneumothorax on your chest x-ray and you're looking at your chest tube water seal chamber and you're seeing bubble, bubble, bubble on inhalation only, then you might want to let somebody know, hey, we've developed a pneumothorax. The treatment's already in place. No one's probably going to freak out about it, but it is something that you would want to notify a doctor about. You would also probably want to talk with a coworker, especially if you're not comfortable with chest tubes. If you have continuous air bubbling in your water seal chamber, that is not normal, not connected to a pneumothorax. Pneumothorax means intermittent air bubbling. Continuous air bubbling in the water seal chamber means your system is broken, and you might need to double check with your charge nurse or another coworker or somebody on how to change out the drainage system to get that fixed. So just if you do see any of these not expected things, just double check your system to make sure it's working. And if it is a new pneumothorax where you didn't have any bubbling before and now you've got intermittent bubbling, just notify your physician and let them know that the pneumothorax is developing, because that will be something that'll be important to them. If a pneumothorax has developed where there wasn't one before, they'll want to know about that. So anyway, but even if you see continuous air bubbling and air leak in your system, you'd want to check your chest tube and system for loose connections, cracks, talk to somebody about how to replace that cracked system. This is not something I'm going to test you on how to set one up, but you may see chest tubes in clinical, and I would want you to know what to look for. The first thing we look at is always the water seal chamber to make sure it's full, because it's a required chamber, and to see if there's air bubbling in it. Intermittent air bubbling equals pneumothorax. Continuous air bubbling equals a crack in the system that needs to be replaced or sealed. And those are the two things that we do not expect in a water seal chamber. The suction control chamber, this is just make sure it's set as ordered. That's all we need to do with the suction control chamber, is make sure that the suction is on and is set as ordered. You can see in this bubbling one here was the line that I was talking about. These are the two different systems. This one is the wet system, and this one is the dry system. And again, the only difference between those two systems is what the suction control chamber looks like. They both have a water seal chamber. The wet system, this is your measurement. If the water is up this high, you are at 20 centimeters of suction. If the water is this high, you are at 15 centimeters of suction. If the water is this high, you are at 10 centimeters of suction. So basically the water level determines your suction level. And on this one, it's dialed. You dial it to the correct level of suction. Much, much easier. One of the problems with these wet systems, the other reason I like to get rid of them, is in Arizona we have evaporation. So a lot of times the doctor will order 20 centimeters of suction, and you'll fill up the line to 20 centimeters and set this thing off bubbling, and you're like, yeah, it's great. Hey, it's all working. But after a day or two, it evaporates down, and now your water level is here, and you're not sitting at ordered suction. So you have to keep refilling water in Arizona into a wet system. It's best not to get involved with it, but if you do see a wet chamber, the check to see if your suction amount is the same as the order is the level of water in that side. That is your order. So if your water is here, you're at 20 centimeters of suction. If your water here is, you're at 15. If your water is here, you're at 10. And if your water is here, you're at 5. You can see on this one, it's easily dialable, and you can see it actually goes up. 20 is the max on a wet seal. 40, you can get a lot better suction on this chamber. So it depends on your doc's order. If your doc orders negative 40 centimeters of suction, you cannot use a wet chamber. You won't get 40 centimeters of suction. So you would have to get a dry chamber. So you might as well just get a dry one to start with. So that is what you're looking for in the suction control chamber, is just make sure that your suction is to order and that the suction is working. The reason you know suction is working is that there is bubbling in a suction control chamber. This is continuous bubbling. In a wet system, the suction should always be on, and so it's always bubbling. That is different than the water seal chamber. Continuous bubbling in a water seal chamber is a muy malo bad thing. We don't want it. It means there's an air leak in the system. In the suction control chamber, it's an expected finding. And so I think wet systems are so confusing, because you're like, where am I supposed to see bubbling? I'm not sure. I don't remember. Bubbling just means that the suction is on in the suction control chamber. So when we talk about this chamber, we do want continuous bubbling I can't spell again. I'm trying to write. We do want continuous bubbling because we want the suction on all the time. So we do want continuous bubbling. That's fine in a suction control chamber. It is not fine in a water seal chamber. So you can see on this one, the water seal chamber is down here. So here's the water seal and here's the suction. These are two different chambers. This one is no continuous bubbling. We don't want continuous bubbling in the water seal. No continuous bubbling in the water seal. Yes, continuous bubbling in the suction control. So very confusing. I'd rather not confuse people, but unfortunately the system does exist, so we do have this system. So water seal, no continuous bubbling, very, very bad. Suction in a wet system is supposed to continuously bubble. So very confusing, very hard. Much better in a dry system because the water seal chamber is your only water, and you know intermittent's okay, continuous is bad. And here's how you know if your suction is working, because this little bellows is showing in the window. If the bellows is not showing in the window, the suction is not on. So anyway, that is basically all you're doing with the suction control chamber, is making sure that it is at the correct suction order and make sure the suction is on. And in a dry system, you know the suction is on because the bellows is in the window there. If you have a wet system, the suction is on if it's continuously bubbling. So that's all we need to do with the suction control chamber, is put the suction at the right amount and keep the suction on. That's easy enough. The collection drainage container is, we expect drainage to be present. The system should always be below chest level, just like Foley's need to be below bladder level. Again, there is a suction component to them, but they are drains. They need to be below the level of what they're draining. So they need to be on the floor, below the chest level. Do not carry them on the ends of the beds except for transport, because if they're on the end of the bed or hanging off the end of the bed, they're at the same level of the chest usually. They don't drain as well. They should be on the floor, just like a Foley catheter needs to be down low to drain. So does suction. So does a chest tube. So make sure the drainage is present. Monitor the drainage. Document the amount and color of drainage. You can see on this bottom one here, this is kind of serous fluid. It's all yellowy fluid. This is pleural fluid. This chest tube needs to be changed. It's all the way full. So you can see it's sitting here at its max amount. No more fluid can get in here. That means we cannot drain anymore. This whole drainage system needs to be changed out. There's no way to dump these systems. You have to replace the whole collection container. Mostly we don't want all that fluid just sitting there collecting bacteria and stuff like that. Bacteria could climb back up the tube. So when these collection chambers get full, we change them out. And that is the only time we will clamp the drainage tubes. Again, just like you won't clamp a Foley, you shouldn't clamp a Foley, because if a Foley is clamped, it's not draining urine and you can cause a backup into the kidney. If a chest tube is clamped, you can have chest tube drainage not getting out of your system, and that would be bad. So we would want to change the system out. Again, we're not testing you on how to change systems or anything. You would ask a coworker or a charge nurse or somebody if you've never changed a collection chamber system before. The collection chamber where you change it is right here. You just get a new system out and pop the old system off and put the new system on. You can see she's got the clamp right above it here. This clamp would close, and you would close it off, disconnect it, reconnect the new one, and then reopen the clamp. But again, the drainage collection chamber, you're really just keeping track of what the color consistency of drainage is, what the amount of drainage is. Because they don't get emptied or changed, what you will see is nurses will mark the drainage on them. So they'll mark here, and then the next shift they'll mark here, the next shift they'll mark here. They'll just keep marking the drainage and probably time and date the drainage so that they know when this was marked, and you just keep track of it until it gets full, and then it gets changed out. Anyway, it's just you can't dump it like a Foley. There is no way to dump the fluid out of there, so stays until it's full, and then you change out the collection chamber. We don't expect also more than 100 milliliters an hour of drainage. That's starting to get to be a lot of drainage. I would let the doc know if you have over 100 milliliter hour of either effusion drainage or blood, because that's starting to get into a pretty significant fluid loss. So really, basically, we expect it to we just keep monitoring the drainage. We'll replace it with full or notify the physician if there's greater than 100 milliliters an hour of drainage, because again, that starts to be an I&O concern. Like, we shouldn't have that much fluid in there to drain. Is there a process that is creating more fluid, or is there, bleeding going on? Something that the doc probably needs to check out. So really, the water seal chamber, the summary for the water seal chamber is make sure it's full, make sure it's tidling. So we want to make sure it is full. Go back. Make sure it is full, make sure it is tidling, and look for air bubbling. Intermittent is okay if pneumo. We don't mind intermittent in the water seal chamber. Okay if there's a pneumo around. We do not expect, this is not good, continuous air bubbling in the water seal chamber. We also don't want intermittent air bubbling if there was no pneumo. That means it's new pneumo. So make sure that you let the doc know if you have a new pneumo or continuous bubbling. You'll have to address that with the system. So water-filled tidling, that should be all you see. The only other addition that's okay is intermittent air bubbling. If you know you have a pneumothorax, it means air is escaping. Suction control chamber, all you're doing is making sure that you have your suction amount and that your suction is functioning. And that is the only time we will see continuous bubbling, is if you have a wet suction device, and the bellows will be visible if you have a dry suction device. So again, continuous bubbling is okay in the suction control chamber. It is not okay in a water seal chamber. Okay. And then the drainage collection chamber, we're really just monitoring the amount and type of drainage, unless the drainage container is full and we'll have to change it out, or unless the amount is too high and we'll let the doc know. The other things we're looking at is the actual dressing and tubes itself. We want the connections all tight and taped, because if like any of these things come apart, which I show you in the video, if any of these connections come apart, then air will get into the system and cause continuous bubbling. So that would be something that we need to look at. Make sure your connections are tight and taped. If this has come loose, so there's no Vaseline gauze around it, you might be getting air in and out of the system there, causing continuous bubbling. So you want to make sure your dressing is clean, dry, and intact. Your chest tubes are not clamped and everything is intact. One more thing to talk about on here is if your chest tube is accidentally dislodged. If it is accidentally dislodged, you get a special 3-sided dressing. You'll get to use this again in emergency nursing, because the 3-sided dressing is for a sucking chest wound. If your chest tube becomes dislodged, you basically have a sucking chest wound. You have a hole open to your chest. So if the chest tube pulls out, you have an open hole. If you are going to exhale, you're going to pull air in from the atmosphere. So air will be able to get into this hole. The 3-sided dressing keeps air from getting into that hole. But then when you exhale out, air can get out of that flap. So that way, if you have a pneumothorax, air can escape. The 3-sided dressing allows air to escape out, but not air to get in. So a 3-sided dressing is great for any sucking chest wound, a stab wound, a gunshot wound, or anything like that, which we'll talk about in emergency room nursing. A 3-sided dressing is basically a gauze over the sucking chest wound, but only tape it on 3 sides so that when you inhale, and air can go out without it'll escape out so that that pneumothorax can resolve. So a three-sided dressing is the emergency procedure if your chest tube comes out. Of course, you'll call the doc, go a full respiratory assessment, and probably get a chest x-ray order from your doctor to decide whether they need to replace the chest tube or not. But you're going to need to check your patient's respiratory status after the chest tube becomes dislodged to see what's going on. But the first thing you do, cover the area with a petroleum gauze, three-sided dressing that allows air out but no air back in, and then do your call the doc, but do your respiratory assessment while you're waiting for the doc to call you back, because you need to address this, and we're not going to put a chest tube back in. A doc has to put the chest tube back in. So best thing would be to make sure that everything is tight and taped and clean, dry, and intact so that your chest tube can't become accidentally dislodged. But if it does, that's your emergency procedure, is a three-sided dressing. The last thing is our last procedure is a thoracotomy, where we actually physically do something surgical to the lung. Most thoracotomies now, they could be done open, which is the top drawing here. This is an open thoracotomy where they physically open up the back side of the chest. And remember, the back side of your posterior chest is where there is most lungs, so that's why the procedure is done from the back side. You can access all of your lungs without your heart and your rib cage and everything in the way. Well, actually, your rib cage is back there too, but they can separate that out. But you don't have heart, blood vessels, and everything like you do from the front. The back side is a much wider bit of your lung, and you can access most of your lung from your back side. So when you're really listening to your lung sounds, listen to them from the back side. You're hearing more of your lung that way than if you're just listening to the tops of your lungs and trying to listen up under breast tissue and chest tissue. Listening from the back side is actually better for respiratory assessment, and it's better for a thoracotomy approach. It's around lateral to the back side. That's an open thoracotomy. The laparoscopic version is called VATS, video assisted thoracic surgery. So they have two different kinds. This is where they could biopsy a piece of the lung, remove a portion of diseased lung, cancerous lung. They can physically go in and drain out tubes, drain out blood, air. Any surgical procedure for the lungs could be done either via open thoracotomy or VATS procedure. Afterwards, a lot of times, if you're going to cut the lung or do an incision in the lung, what do you think you're going to have afterwards is a pneumo, because you cut lung tissue, it's going to leak. So most of these thoracotomies or VATS procedures come out with chest tubes afterwards, and we're not too surprised to see intermittent bubbling in the water seal chamber because there's a pneumothorax, because if you cut lung, every time you breathe in, some air is going to escape around the sutures and stuff, and so you know you're going to have a pneumo. So after most of these surgical procedures, the chest tube is in place just to maintain that air removal while the lung is healing. So after you cut lung, you're going to lose air out of that, and so chest tubes are in place after a thoracotomy procedure. This should say after, I guess it's after procedure. It could be chest tube or thoracotomy. It's the same thing. So we're just going to write chest tube / thoracotomy. We expect dressings, we expect chest tubes, we expect pain and pleuritic chest pain. Again, we have chest tubes in place. You've just done surgery on lungs. It's going to hurt every time they breathe. We do not expect new pneumos. We don't expect bleeding hemothorax. So again, I'm going to say that we actually, trying to think what I was copy pasting this slide off of. I guess this is chest tube. For thoracotomy, we would expect a pneumo. It's expected because, heck, we just cut the lung open. So I expect some pneumo after a thoracotomy. But with a chest tube, we should hope that they don't have a new pneumo. We can escape a new one, but we don't want a new pneumo. Bleeding hemothorax, again, both of them. If they're bleeding if they put the chest tube in because of a hemothorax, we expect to evacuate that, see that out in the tube, but we shouldn't see more and more and more bleeding. That is a new process. We don't expect to see a lot of bleeding and hemothorax post-surgery. That means that there is bleeding going on post-surgical. So the chest tube is kind of a window post-thoracotomy or post placement. We can kind of see what's going on that lung field by watching the drainage collection container. So I think I put both of these things together. They're kind of mixed up in there, but any chest tube or thoracotomy, we expect the same things, and we don't expect the same things. I would say the only change on that is we do expect a thoracotomy to have a pneumothorax afterwards. They cut into lung tissue. It's going to leak air a little bit, no matter how well they try to seal it up. Sutures aren't completely airtight. So I would expect a small pneumo after a thoracotomy. I wouldn't expect something big or, a huge air leak in the system. But otherwise, we don't expect any new or worsening pneumothorax going on after a procedure. So I think that is it for this lecture. It was more than long enough. I will forward you on to the respiratory failure lecture, and we'll see you soon.